So in terms of experiences with using some of those other agents, the radiopharmaceuticals, I imagine you're probably going to have the most experience when we're talking about some of those other agents. What are you seeing in terms of what's coming out, what's being used currently in addition to radium-223, and how does it fit in the treatment pathway? Because when all this new stuff started coming out, I remember my initial response was, it's a replacement. And it's certainly not, but I was curious as to your...
So I think, lutetium originally says it's for patients post-Taxotere or who aren't eligible for, which is a very interesting caveat in there.
Yeah.
Because there's a lot of people in that second group. And so, we had Xofigo or radium-223, and then, you have to watch the blood count so you can get some anemia. Same thing, you have to watch that with lutetium. It's a fascinating segue to get to what you're asking about these newer agents. So Dr. Stroop said he ran cross country. I did a lot of cross country. My coach from high school, I got varsity my senior year, but I was never one of these real studs. But our coach won state 5 out of 6 years in the 70s, so he's a legend. Yeah. He took them to Colorado and he'd run them up and down the hills at the end of the summer, which you can't do anymore. But he'd make them probably polycythemic, and they would come back and they won state, and they just were this amazing team. So anyway, he is, prostate cancer. Yeah. Anyway, got it in the trial. PSA was climbing rapidly, wasn't looking good. I think he was post one of these therapies. Maybe it had a radium-223. It was looking grim. And he was in hospice. He went to clinical trial, got an actinium, I think. An actinium, a newer, his PSA's dropping like a stone.
Wow.
I mean, he has a cranial nerve deficit. He has to wear glasses because his eyes, so he's got like an esotropia or exotropia. Anyway, I mean, it was looking really grim, but he's pulled out of it. And I mean, so it's amazing to see these new things.
Yeah.
Access to clinical trials and new agents, things that are coming, that will be coming.
One of the things I am faced with, I really struggle with is, no one knows sequencing, but add in all the germline and genetic information, now we really don't know sequencing.
Right.
So some of my sequencing isn't about what I think is going to be most efficacious so much as what's not burning my bridges. And when you have PARP inhibitors affecting, bone marrow, any type of radiopharmaceutical, are you guys seeing, from avoiding a detriment to marrow, is there a strategy that you would come up with to say, look, I want to save docetaxel for the end, or hit them really early with docetaxel? Is there anything you're seeing that would make any lick of sense?
I think it's, we see PARP inhibitors usually seem to be sequenced later. That's something we kind of save for later in general. Okay. That's what I think I've seen. I think docetaxel is not one you want to save like third or fourth line, because I mean their performance status, if it's shot, they're not going to have any bandwidth. Ironically, Jevtana, cabazitaxel, is almost the same molecule as docetaxel. It's just there's one little position that's flipped, and they took that off the shelf and realized post-docetaxel, that's better tolerated with some diarrhea. And in that trial with cabazitaxel, they had some non-American patients, and so you have to watch out for the diarrhea that can happen, because Dr. Bryan, you had a great point about these trials. We were always taught in training, look at the methods section of your clinical trials. That's where you have the real substance, And so you want to, make sure if you have some patients that are, if there's some diarrhea signal, life-threatening, well, if they're not having the supportive care in another place, But cabazitaxel, that's one, post-docetaxel, I've seen significant benefit. You can, it's not years, but you can really give them some extra time. It is going to be a very interesting challenge to see how do we sequence these. Is there going to be anything that can be, we did this, I'm sure Dr. Agarwal with precision medicine looking at saying, hey, we're going to, look what we have in lymphoma. This is an activated B-cell lymphoma versus germinal center. The germinal center does better than activated B-cell. And, breast cancer, talking about luminal subtypes. And so the more we can kind of divide and say, hey, this person will be best served with this regimen. So that'll be nice if we can get to that
I think castration-resistant prostate cancer, I mean, a clinical trial is obviously really nice. You've reached that point. And right now, prostate cancer has kind of remained out of the surveillance of the immune system. For some reason, immunotherapy obviously hasn't really worked well, even if they're, quote unquote, tumor mutational burden's high and MSI.
Right.
It's just not a great option for prostate cancer. So there's a lot of trials now and companies working on unlocking the, immune surveillance to make your immune system primed for
The
treatment.
CTLA-4, is that what we're talking about there?
Well, there's some of that,
Yeah.
and then there's even some new trials with ablative therapy where you ablate a metastasis, allow the antigen to be released, and they inject this trial drug.
Interesting.
And the trial drug unlocks that immune potential. So you ablate it, and then you have this immune kind of activator. And CTLA-4 is sometimes plus or minus. They've actually done that with some of these trials. I mean, these are like phase 1
Yeah,
trials.
right.
But one of the patients I saw when they were presenting it, it was at AACR also. The patient was, hospice, basically. 100 bone metastasis, essentially. And he got injected with this. A year later, he's cancer-free completely. I mean, remarkable story,
Yeah,
right?
right,
So
right.
these things are coming along where I do think in every other cancer type we've had, the immune system has won over all other therapies,
Yeah.
right? Bladder, kidney,
Yeah.
melanoma. Immune system, if you can unlock its potential on prostate, it probably will win too. There's
LAG
no other
inhibitors.
cancer that's like that.
Like LAG
Yeah.
inhibitors, that's
Yeah.
another class with melanoma,
Oh, yeah.
It'll be interesting to see. What you're getting at too is a lot like for stage 3 lung cancer, we do 6 weeks of chemoradiation, 30 fractions of radiation, chemo once a week. Then you hit them with a year of consolidation durvalumab, immunotherapy. And that's kind of like you said, you unlock the
to
immune
be able to
system.
unlock it somehow,
Right,
'cause
and all
right
those
now it doesn't-
antigens are exposed
Exactly,
after all that
exactly.
chemoradiation, so that's...
I'll be curious how it works.
It will. Go ahead. It's in your guys' opinion. I think there's 2 things are going to happen in terms of how we move the needle, and one of them is quite obvious, and it's the things that are late stage are going to move earlier and earlier in stage to get the outcomes. Then there's going to be the unlocking, the thing that we're not talking about. What do you think is going to be the big move? Is it going to be something we don't know about yet, or is it going to be that's so we've exhausted so many things? I'm talking about in the next 10 to 20.
Yeah.
I mean, obviously, as many years down the line, it'll be something that we've never thought of. But next 10 to 20, you think it's current therapies moving sooner, or is it going to be a diagnostic test? We got genetics, PSMA. We're lowering thresholds. Or is it going to be something that we're not sitting talking about right now?
How about a fascinating question if just the general population was exercising a whole lot more, eating better, not all the processed food.
Yeah.
That along with the PSA screening, the USPSTF saying don't check PSAs,
Yeah.
which you just hope that's going to, it's like with treating chronic pain, the pendulum just went way too far the other way. Overdiagnosis, just don't testing.
So you said it really well, actually. I was thinking about it today because there's an article that came out in JAMA, I think, and somebody wrote an opinion about it, about over the last 50 years since the 1970s, what's had the greatest impact on cancer death. And it is prevention and screening, right? Doing late-stage treatment for castrate-resistant prostate cancer is not having a huge impact on patient quality of life or death. And so, Pap smear is a great example, right? They brought up that is that nothing's changed in cervical cancer treatment in 30 years. But Pap smear alone, now with vaccines, it's moving the needle for saving millions of women's lives, right?
Yeah.
PSA screening, mammography, colorectal cancer screening, it moves the needle on prevention, right? In screening, and then prevention, which you talked about, is obviously important. But part of that is a risk-adapted screening strategy, right? If we know that for instance, monogenic risk is pretty high with BRCA-ATM, I should have a risk-adapted screening strategy and prevention strategy. If I have a polygenic risk, right? We have monogenic, then we have polygenic risk scores that come into play. Then I'll have a different risk-adapted strategy for how often I get screened and then what I do for prevention. There's some trials now open that if you have a monogenic risk or even polygenic risk, there's a chemo-preventative agent that you're on in addition to lifestyle, which is kind of extreme, but it's actually pretty interesting. And so I think that's going to have the biggest needle. We have to move back to that prevention and screening to make the biggest impact and do it in a better way.
Well, I think that's the key, because mass screening is not going to
risk adapted
take care of it, right? I mean, that was the problem in the first. That's how we moved the needle too far the other way. You screen everyone. You say, okay, well, you're 85 and keep getting your PSA. I mean, you're not moving the needle anywhere, right? I mean, I think those are some of the old VA studies, right? You're more likely to get your PSA at 85 than at 55.
That's interesting. That's a good point.
So, you can't just open it wide back up again. So
So catch it earlier.
100%.
Yeah. I
Maybe
love it.
patient education too. I mean, there's at least 2 guys I know at least 2 said, I'm never taking any androgen deprivation therapy, period. And just to help people understand, listen, we can help you get through this. We can support you through it. I mean, I literally have had somebody who, the urologist couldn't believe, he's like, this guy just refused. And he never got, and so just with education, you can let them know, and with these newer oral targeted therapies, we can really translate to benefit.